drugs, or ideas, what you consume influences who you become. On the Mind and Matter podcast, we learn together from the best scientists and thinkers alive today about how your mind-body reacts to what you feed it. Before starting Mind and Matter, I spent 10 years in academia doing scientific research. I got a PhD in neuroscience where I focused on neuroendocrinology and the neurobiology of behavior, and before that, I specialized in molecular, developmental, and evolutionary genetics. I use my scientific background to help parse and translate the information that guests share on the podcast. In addition to the podcast, I write long-form written content inspired by the show where I integrate what I've learned across episodes. I also have a free weekly newsletter where I provide you with upcoming guests, share links, and provide commentary on scientific studies and research that I'm reading, and more. Visit mindandmatter.substack.com to find all of my content. The full version of this episode is available to paid subscribers at the Mind and Matter Substack at mindandmatter.substack.com. The full version is also freely available on my YouTube page. Just look up Mind and Matter or my name, Nick Jikomis, on YouTube, and you'll find the episode there. This is a partial version of the episode, and so it'll cut off partway through, but you'll still get a significant portion. So sign up to become a paid subscriber at Substack or visit my YouTube page to get the full episode. Kulldorff, welcome back to the podcast for the second time.
Thank you so much. It's a great pleasure.
Yeah, I really wanted to talk to you again. I talked to you back in early 2022, I believe, which was, very much the before times. We were still in the midst of the COVID pandemic, and it's been maybe 3 years now. And I definitely wanted to talk to you again specifically because of what we discussed last time, and because it's been 3 years. We've all lived through the COVID era. We're in this sort of new phase of the pandemic and how we deal with it. And people have had 3 more years of experience, personal experience, and lots of new evidence, lots of new things to discuss. But I just wanted to touch base at first. Do you want to remind people who you are to get us started, and just talk a little bit about your background as an epidemiologist?
Well, I'm an epidemiologist and a biostatistician. I worked for a few decades on infectious diseases, on the early detection and monitoring of infectious diseases, as well as on monitoring the safety of vaccines.
And so last time I spoke to you, again, it was 3 years ago. And at that time, for those who don't remember, at that time, and maybe even today, still to this day for some people, you were kind of considered a controversial character. Can you talk a little bit about why that was and why people perceived you to be somewhat controversial at the time?
Well, I think that's true. Maybe not so much anymore, but if you go back 5 years in 2020, where the country was closing schools and doing lockdowns, and people weren't going to the hospitals when they were supposed to because they were afraid of COVID, etc. That was not done according to the basic principles of public health or evidence-based science. So most of my colleagues that I work with, epidemiologists, they did not agree with those lockdowns that Anthony Fauci and Deborah Birx and others imposed on us.
So most of your colleagues, most of the people with your background, epidemiologists who study this stuff, didn't agree with the way things were going, even though a lot of people weren't saying that publicly, though, right?
That's true. And I tried to say it publicly during the spring and summer of 2020. And I was able to do so in my native Sweden. I published in the major daily newspapers there. But in the US, I failed until August, when I finally was able to publish something about school closures in CNN. But not the CNN that you think. It's CNN Espanol. I know how to write Spanish. I figured, okay, if I can't publish in English, at least maybe I can publish in Spanish. So
Wow.
CNN Espanol published a piece where I was arguing that Sweden did the right thing not to close the schools, so we should open all the schools. CNN in English were not interested in it. But then in October of 2020, together with Dr. Jay Bhattacharya at Stanford University, and Dr. Sunita Gupta at Oxford University. And at the time, I was a professor of medicine at Harvard University. We wrote a one-page thing that's called the Great Barrington Declaration, where we argue that we shouldn't lock down society. We should do much more to protect older people because they are at the high risk of dying from COVID. So
Hmm.
we were not doing enough to protect older people, but then we were closing schools, which is very harmful to children, and we were closing down society, which has enormous public health impact, which we now have evidence for in people are not getting the cancer treatment or cancer screening they need. There were increased problems with cardiovascular disease that were not properly treated. People were dying at home instead of going to the hospitals. Problem with diabetes care, mental health, of course, very much so. So the list is sort of long of all those other aspects of public health that we ignored
Hmm.
to our detriment. And the only country that sort of opposed this lockdown uh, philosophy was Sweden. And we now know that during the pandemic, Sweden had the lowest excess mortality among major Western countries. So it's clear that Sweden did the right approach to focus protection on older people while letting children go to schools and having younger people live more normal lives.
Hmm. And so after talking with you last time and after having, the last few years to learn and to think about things, I just want to emphasize for people and correct me if I'm getting any of this wrong, but your position not to do lockdowns, not to close schools, and to focus on protecting the vulnerable, which in this case means the elderly or people at risk for severe COVID who have certain comorbidities. That is literally textbook epidemiology. This is not, even though you were in the minority of in terms of people publicly saying this is literally what's in textbooks. It wasn't some crazy, wacky thing that you were just coming up with.
No, that's the basic principles of public health, part of that. And actually, if you go and read some of the pandemic preparedness plans that various countries had prepared before the pandemic, that was basically what people were recommending. You can't just close down society because it has such enormous negative consequence, collateral damage on public health.
Mm-hmm. And
So,
when I think back to the early pandemic, the first year or two, one of the things. So obviously, when this at the very very beginning, everything was mysterious. This new virus was spreading. Nobody knew exactly what it was or how it worked or how deadly it was. And I want to remind people who may have forgotten. In those early days, there was a lot of uncertainty. And one of the things where there was a lot of uncertainty and controversy that I remember was how deadly is this virus? How deadly is COVID exactly? And people started talking about something called the fatality ratio, basically how what are your odds of dying if you catch this thing. And early on I remember that people thought it could be potentially quite deadly. I think the World Health Organization was saying the IFR was 3 4 5%, maybe even higher. And then at some point, a man who I think you're familiar with, John Ioannidis, very well known in the research world, he had a paper come out and he predicted the IFR was actually much, much lower. And that caused a lot of controversy at the time. Do you remember that episode? And can you talk a little bit about how deadly the virus is and what we know about that right now today?
yeah, so that's called infection fatality rate, which means if you're infected, what's the probability of dying?
Mm-hmm.
And it's true that in the early pandemic, there were uncertainty about that. Uh, but what was not uncertainty about was the relative risk
Mm.
comparing different people. So, yeah, so back in February, March of 2020, I did some calculations just by hand, look based on the Wuhan data, and we could see then that who died, and there was mostly older people. So I did calculations then and found that the risk of dying from anybody can get infected, but the risk of dying from COVID was more than a thousand times higher among older people versus younger people. So from the very, very beginning, we knew that one, there was a huge difference in risk by age. So that was the most important
Mm-hmm.
risk factor. And two, children and young people were safe from this disease. They would not be dying from it. So we knew that very early on. but you're right. We didn't know whether the infection fatality rate was 0.1%, if it was 0.5%, 1%, 3%, or 5%, and
Yeah.
various numbers was floating around. And you're right that John Ioannidis, as well as Dr. Jay Bhattacharya in Stanford, did what's called a zero prevalence study. They knew how many people had died, but they didn't know how many people were infected. So they
Hmm.
did a survey where they take a blood test to look at the zero prevalence to see have you been infected or not, to find out what the risk was of dying. And for some very strange reason, that became extremely controversial. I think the controversy should not have been that they did this study. It's called the Santa Clara study because they did it in Santa Clara County, which is just south of San Francisco.
Hmm.
The controversy should have been why CDC didn't do this at the national scale,
Right.
because this study in Santa Clara was done like on a shoestring budget
Yeah.
with volunteers and all kind of things. But that was the job of CDC to quickly
Hmm.
do that surveys in different parts of the country and do it like week by week and month by month to see how many people were infected. And they completely failed in their task by
Yeah.
not.
So I mean, you would have expected the CDC to do a big study like that because there was uncertainty, and this was
Yeah.
this major pandemic we were going through. You would think, just commonsensically, that they'd want to get very robust, very robust data from a large scale study, and that didn't happen. And then, as I recall, when some of these estimates, like from the Santa Clara study, were coming out, they were saying that the infection fatality rate was lower than many of the other estimates that had already been coming out. And for some reason, this was causing controversy. Some people didn't like the idea that the number they were coming up with was much lower. In other words, that the pandemic was going to be less deadly for most people than other estimates were implying. And one of the reasons I think some of these estimates differed is that they were making different assumptions or having different estimates around the number of people actually infected. And as I recall, the reason for this, or a reason for this, is that some of these studies were not taking into account that there were many asymptomatic people who were infected, but we didn't really sort of realize it because they didn't have symptoms. Can you talk a little bit more about how prevalent asymptomatic spread of this virus actually is?
No, you're 100% correct. So people were mixing up infection fatality rate versus case fatality rate. So if you have a case, means that you are diagnosed, you have some symptoms that may be serious enough to go see the doctor, and then uh, how many of those cases were actually led to death. But infection fatality rating also includes all those who were infected, many of which might be asymptomatic, or they may have some symptoms, but they never go see the doctor, so that never became an official case of the disease. So obviously, the case fatality rate is always larger than the infection fatality rate, and they were sort of confusing these two numbers and treating the case fatality rate as the risk of dying from this disease if you were infected, which was not the case. Uh, so that's why there was a confusion. We know that there are asymptomatic infections and that there are more among young people and children, but I haven't seen a reliable number exactly how much that is. And of course, we now also know that you get immunity once you have it, but you can still have it a second time,
Mm-hmm.
although it's not as dangerous. But so somebody can be asymptomatic the first time, but then have symptoms the second time and so on. So
Mm-hmm. Yeah, and based on our last discussion, one of the things I think you emphasized well is the fact that you get that this virus is quite contagious, but also that it can spread from asymptomatic people, right? I might have the virus. I don't have symptoms, and then you catch it from me, but neither of us realizes that I'm even sick because I don't have symptoms. It's actually that reason why your position and the position that you find in a lot of epidemiology textbooks is you would want to implement a focused protection strategy for the vulnerable for a virus that spreads like that, rather than something like a lockdown, because something that contagious that can spread asymptomatically is simply not going to be contained.
correct. So it started in Wuhan in China, but then the two areas outside of China that sort of had a big outbreak first were northern Italy and Iran.
Yeah.
And we didn't know who brought it in there.
Hmm.
So it was sort of spreading under the surface without
Right.
we be able to check it. And that meant that it was very obvious to me and to other infectious disease immunologists that it was impossible to contain this disease. It will spread sooner or later to all parts of the world, which is exactly what happened. And that's not strange because influenza is the same. It sort of spreads throughout the world and it's impossible to sort of contain. And that's different from something like Ebola, for example. So we had some cases of Ebola in the US, and that's a very serious disease, and people have symptoms when they get infected. So there is a situation where you want to isolate those people who have Ebola so they don't spread it to others. And then
Hmm.
you do what's called contact tracing. You see who did they meet with. Want to check if they were infected, and then if they are infected, you want to
Hmm.
isolate them too. So contact tracing and isolation of individuals is important for a disease like Ebola because
Because it's
you don't
clearly
want,
symptomatic and it's very deadly.
yeah. But to do contact tracing and in isolation for COVID is hopeless.
Because
Just
you have so
again,
many people without symptoms.
yeah, symptoms or very mild symptoms. So just like influenza, we cannot sort of suppress it. There was a movement like called it zero COVID who wanted to eliminate COVID, but that's impossible. So that just created a lot of collateral damage without any prospect of success.
Yeah. So because it's not feasible to contain and get down to zero for something that contagious that can spread asymptomatically, and because it's inevitable that there will be downside to doing something like lockdowns, basically there's only downside, there's no upside because your attempt to contain that contagion is going to be futile.
Yeah. So what you can do is you can push it a little bit into the future.
Hmm.
But that's also a principle of public health. You just don't want to push the problem forward.
Yeah.
So it's not like if we have a hurricane, for example, well, the hurricane comes, you hunker down during a few days, and then the hurricane is over, and then you can come up and resume normal life. Uh, but infectious disease doesn't operate that. If you hunker down for a while, it might maybe you can sort of hold it off for a while, but as soon as you sort of come up again, then it will spread.
Yeah. The
You can
hurricane's
just
going to
postpone
come
it
no
a little
matter
bit.
what.
You cannot prevent it.
Yeah. Another thing I want to ask you about in terms of like textbook epidemiology and immune biology is like historically, so obviously what happened with this pandemic is the virus started spreading, and then we introduced these new COVID vaccine like technologies, these new mRNA shots during the pandemic while we were still in the midst of a pandemic. Historically, is that the way that things have been done when we come up with vaccines? Where historically, what happens when you have a new vaccine? Do you want to, or is it advisable to do that during a pandemic, or do you normally wait until after the pandemic has stopped spreading on its own?
No, if you can get a vaccine during the pandemic, that's good.
Okay.
I think there were every reason to try as hard as possible to develop vaccines.
Hmm.
Now, there are problems with uh, how that happened, but the principle of just trying to get a vaccine, that I think is good, and you want to do it as quickly as possible.
Hmm. Some people have argued that when you roll out a vaccine like that in the midst of a pandemic that's spreading very widely, it creates evolutionary pressure for novel variants of the virus to evolve that can escape the vaccine induced immunity. Do you have thoughts on that, and whether or not that can happen?
I think that could potentially happen, yes, but I don't think it's an argument against trying to develop a vaccine.
Hmm. And so obviously the vaccine.
The lockdowns also can change those things because
Mm.
that can sort of force mutations to new mutations and sort of promote new mutations of the new variants of the vaccine or the virus. So lockdowns can also have that impact on the virus.
Mhm. The other thing I want to talk about is natural versus vaccine induced immunity. And obviously, we can talk about COVID stuff, but I want to ask you about this in more general terms. Can you talk just a little bit about the difference between natural and vaccine induced immunity? What are those two things? And in general, do most vaccines produce an immune response that's very comparable to what you would get from actual exposure to a pathogen? Or is the immune response typically different between those two?
Yeah, so we have known about infection acquired immunity or natural immunity
Mm-hmm.
for about 2,500 years, since 430 BC during the Athenian plague is described. So that's about the same amount of time as we have known that the Earth is not flat, but like a sphere around. So this is old knowledge
Mm.
that we have immunity to disease once we have recovered. Um, Now, a vaccine is sort of trying to mimic that natural immunity without having to have the disease, so
Yeah.
without the risk of dying. So it's sort of mimic or is triggering your own immune system to react and create that immunity.
Yeah. And I suppose, I mean, it makes a lot of sense. To the extent you can mimic that response, you'll get immunity, which is good. And you don't have the downside risk that a disease can have, which is that it could really, really permanently damage you or even kill you.
Correct. And uh, a good vaccine will give you almost as good immunity as infection-acquired immunity. Uh, some are close, others are far from close. But you would never expect infection-acquired immunity or vaccine-acquired immunity to be superior to infection-acquired immunity. That would be astonishing if that happened.
Yeah. And
So during
that
so
makes
during yeah
sorry, that should make intuitive sense, right? Because the way that vaccines work, once you dig into the details, they're rarely going to expose you to all of the antigens and components of the natural bug, and therefore the immune response would never be expected to exceed the what you would get from a natural infection. Is that the idea?
yeah. And among the vaccines that we have, some of them are good and some of them are less has less efficacy. But during the pandemic, it was very strange to have um, uh, the CDC director or colleagues of mine at Harvard who were questioning infection-acquired immunity, who were basically questioning 2,500 years of scientific knowledge, to claim that and claims that the vaccine provided superior immunity. So this whole idea, or that those who had recovered, that's very strange. If you have a vaccine, let's say you are the biggest vaccine supporter in the world,
Mm-hmm.
then you don't want to vaccinate the people who already have acquired immunity because you want to use those vaccines for people who actually need it. So we were basically wasting vaccines by mandating vaccines to people who had already had COVID. We were wasting vaccines on people who didn't need it
Yeah,
while
it's
they
just an
were
inefficient use of resources.
yeah, well, there were people like, including my 87-year-old neighbor who hadn't been vaccinated, and many other older Americans, as well as older people around the world, India, Nigeria, Mexico, Brazil, and so on, who had not had it because there were short supply of vaccines. So we were not distributing the vaccines, using them in an ethical manner. And I would argue that if you already had the COVID, it was unethical to force them to be vaccinated because it meant less vaccines for those who really needed it.
Yeah. So not only is there an opportunity cost there, you are giving vaccines to people who already have natural immunity, which is going to be as good or better than the vaccine induced immunity. And that doesn't mean acknowledging the reality of natural immunity doesn't mean we're necessarily saying nobody should get the vaccine. It means we should allocate vaccines that exist, if they exist, to those who haven't already gotten natural immunity.
Yeah, and that's how we used to do things. For example, I'm a huge fan of the measles vaccine. I think it's a
Mm.
very important vaccine. It's a good vaccine, but I have not received the measles vaccine ever. And the reason is I had measles as a child before the vaccine was available. So there's no reason for me to be vaccinated. And that
Mm.
was established medical knowledge for a long time. But then during the pandemic, we suddenly forgot about evidence-based medicine, or some people did, at CDC and FDA and Anthony Fauci and so on.
Why do you think that was? I mean, the people at the CDC and these other institutions, these are right. They're supposed to be the people who know all this stuff, who've read the textbooks, who know what the science says. Why do you were people just in a panic? Did they have ulterior motives? Why do you think that they forgot things that were already well established?
They clearly knew this thing because this is basic science. I know there was a meeting with that Anthony Fauci and Rochelle Walensky, the CDC director at the time, and others had with four academic scientists, including Paul Offit, who is a vaccine scientist, and Peter Hortas, and a couple of others, where they discussed whether infection-acquired immunity should count, and that which therefore shouldn't vaccinate them. And I think there was different opinions in that group, but I think the argument was that the public is too stupid to understand these things, so it's better just to tell everybody to get vaccinated.
Hmm.
I think that's actually counterproductive because people are actually smart. Um, and when they saw that they were mandating vaccine to people who clearly didn't need it, that has generated an enormous hesitation and skepticism towards other vaccines that are recommended. If the CDC and NIH can't get this one right about the COVID vaccine, which is very simple, forcing people to take the vaccine when it's not needed, well, how can you trust them about other vaccines? So it's a very natural thing to ask.
Hmm.
So uh, they sort of complain about what they call the anti-vaxxers, but they were never able to put a dent into the confidence in the vaccine. There was 1 or 2% maybe of the population who was hesitant about vaccines. But the vaccine fanatics of these people, I think they have created an enormous skepticism towards vaccines
Hmm.
now.
So by not talking to the public in real terms, by not saying, "Hey, this is what we actually know. This is the way we should do things." By treating people as adult instead of treating people as adults and just being open and honest. They took this approach where maybe the public isn't smart enough to really understand this stuff. So therefore, we'll just tell everyone to get vaccinated no matter what, even if they don't need to because they already have natural immunity. That messaging approach may have inadvertently generated more skepticism and more distrust than just being open and honest would have.
I definitely think so. So they are the those vaccine fanatics. Those are the cause, I think, of the vaccine hesitancy that we see now.
Mm-hmm.
And I don't blame people who start questioning what CDC have said about other vaccines because they clearly lied about the COVID vaccine.
Mm-hmm.
So of course, people should be skeptical about other things that CDC says.
Yeah.
No, that doesn't mean that CDC is always wrong, because, for example, when CDC says you shouldn't smoke, well, that's very wise advice. You shouldn't smoke because that can cause cancer. So it's not that everything CDC says is wrong. They say many things that are true, but when they get it wrong on an important thing like that, then people are gonna uh, question what other all the other things they say.
Yeah. Yeah. And one of the things, as all of this was happening and I was learning stuff and talking to people like you, talking to other people, reading papers, and then just my own experience, like so many people, my thoughts evolved over time. And one of the things that I think started to get people thinking in new ways and questioning what we've been told and what's going on and what's true and what's not true is, I actually got, at the time in 2021, I decided to get the first two COVID shots. I got the two-dose Pfizer shots. I had not been sick as far as I knew already, and that was just the decision I made at the time, for better or for worse. And but then just when my views started to when I started to have questions and really start thinking in a different way, was just a few months after I got the shots, I got COVID. I got what was probably the Omicron variant at the time, and I thought, well, wow, this is very strange. I got pretty sick after the second Pfizer shot, and then several months later, I got a SARS-CoV-2 infection anyway. And I think that that happened to a lot of people at around that time, and that was really, I think, probably a shift in people's minds, where it's like, okay, I was just told. I mean, I remember very clearly people on the news, the CEO of Pfizer, people at health institutions saying, this vaccine is highly effective at stopping infection. You definitely won't get infected if you get it. And then I got it anyway. And so I thought, well, why did that happen?
No, you're right. The CDC director, Rochelle Walensky, was saying very clearly that if you take the vaccine, you cannot get COVID, and that was not true. And they also said that if you take the vaccine, you can't spread COVID, and that's not true either. So those were an untruthful statement that CDC told the public.
But at that time, did they know that wasn't true and they said it anyway, or did they think it might be true based on the evidence at the time?
So in early 2021, we did not know whether the COVID would, to what extent the COVID would prevent getting the disease. Uh, we actually knew very little. From the randomized trials, which is the gold standard of scientific or medical research, we knew that it reduced symptomatic infection by 95% during the first few months after vaccination. But the randomized studies were not designed to determine whether it reduced mortality or not,
Mm-hmm.
or whether it reduced hospitalization from COVID or not. So we didn't even know that. And they should have been designed to evaluate mortality because, to be quite honest, I don't really care if you have COVID for a few days and have to be in bed. What I care about is you staying alive. So symptomatic COVID disease is not the interesting outcome to study in these randomized trials. The interesting outcome is mortality. But they recruited mostly young people for these randomized trials, and most young people survive whether they are vaccinated or not.
Yeah.
Uh, it's uh, it's older people who will die from COVID. So if they wanted to look at mortality, if this vaccine prevented mortality, they should have recruited mostly older people, but they did not. They recruited mostly young people.
Hmm. So the type of important lesson there is that the result you get in the study depends very heavily on how the study is designed, and
Yeah.
sometimes the headline result can sort of fool us in a certain way if we're not careful about knowing the methodology.
Yeah, and of course, if it reduces symptomatic infection within those first few months from getting the vaccine, you would assume that it also reduces mortality, but you don't know for sure. And they also stopped the trial too early. They stopped it after a few months. They should have continued the trials to see if what was the both long-term efficacy as well as the long-term adverse reactions of the vaccine. So I don't think that they were randomized, which is good. That's very good, but
Mm-hmm.
they were not properly designed to actually answer the important questions. And in terms of transmission infecting others, we don't know if the vaccine could actually um, help prevent transmission, but it could also increase transmission actually. So that's impossible to know ahead of time. For example, suppose you have a vaccine that just reduces the symptoms.
Yeah.
Well, then instead of staying at home in bed, you're going to be out and about at work or at the pub or off playing volleyball or whatever you do, and you might actually spread it more because you don't have as many symptoms. So if the vaccine reduces symptoms, it could be theoretically that it spreads more because you're out and about more rather than being at home and sick and not infecting others.
Hmm.
So this idea that it will reduce transmission, um, and those claims were based on nothing. There was
They were based,
absolutely no
yeah,
evidence, and it could go in either direction for
yeah.
with the vaccine.
So there was no evidence supporting that claim. It could have been true, but no one actually acquired the evidence that showed that.
Correct, and you can actually study that because they could have looked at the so some people randomized to the placebo and some to the vaccine. And they could have looked at the spouses of them
Mm.
to what extent were they infected, or they could look at neighbors or work colleagues or others to check transmission. But so it's possible to do that as part of the randomized trial, but they decided not to study that question.
Hmm. What do we so what's your understanding like today based on all the evidence that we've acquired so far about how effective the mRNA vaccines from Pfizer and Moderna are at stopping transmission? Do they have any effectiveness or is it just weak effectiveness? Full version of this episode is available to paid subscribers at the Mind and Matter Substack at mindandmatter.substack.com. The full version is also freely available on my YouTube page. Just look up Mind and Matter or my name, Nick Jikomis, on YouTube, and you'll find the episode there. This is a partial version of the episode, and so it'll cut off partway through, but you'll still get a significant portion. So sign up to become a paid subscriber at Substack or visit my YouTube page to get the full episode. Hey everyone, I want to take just a minute to tell you about an app I am partnering with called Readwise. Readwise is an app that organizes and helps you get the most out of your digital highlights. I use it to organize all the highlights I make in my digital books on my Kindle, and so if you're like me and you make a lot of highlights and you like to revisit them often to refresh your memory, Readwise is the perfect app. You can also take photos of any physical books you've highlighted and upload those. It also has cool features that allow you to share your favorite highlights and quotes from books on social media, and it syncs with note-taking apps like Evernote, Notion, and Roam. You can tag, search, and organize your notes and highlights on Readwise, and it helps you connect ideas in new ways and retain more of what you read. So if you click the link in the episode description, you can get Readwise for free for 2 months when you sign up for their annual plan. That plan is only $7.99 per month, and it's a relatively new app, so they're adding new features often, and if you sign up for the annual plan today, you can lock in that price, which will stay at $7.99 even if the price increases in the future as they add more. So if you do a lot of highlighting and note taking and you want a good way to organize all that information, check out the link in the episode description.